Hey, welcome to our lesson on cellular regulation and anemia. This is a new concept for you guys this semester. It is, but it isn't, because you've talked about this in the past when you took A&P. So this is just going to be a reminder for you. So if you remember from A&P, the cell is the basic structure of every living organism. They serve specialized functions in the body depending on their location. Cells cluster into tissues, which then form organs. Those form organ systems and then organisms. So the cell that we're focusing on today is the red blood cell, and specifically a lack thereof, which is called anemia. So there's different reasons that this happens. It could be from frank blood loss. It could be inadequate red blood cell production or destruction of that red blood cell. Or maybe we have enough red blood cells, but they're defective for whatever reason, or they're not carrying enough hemoglobin to meet the oxygen demands of the body. So we're going to go over a few different reasons that this happens. It could come from just frank blood loss, right? And this can be acute, something that happens suddenly, where there's a sudden loss of a lot of blood, such as in a car accident. Could be a chronic blood loss, something like heavy menstruation, or loss through the bowels, through ulcers, or maybe cancer. There's a lot of different reasons that can happen. There's a few different nutritional anemias that we're going to talk about, as well as hemolytic, aplastic. The one that we're not going to really talk about in this class is the neonatal, because we're mainly focusing on adults in this class. And just keep in mind that iron deficiency anemia is the most common type of anemia that you're going to be seeing. So when we diagnose this, the diagnostic test that we're looking at is the CBC, the complete blood count. That is one of the most common lab works that you're going to see on any of your patients. So there are some things that you're going to have to memorize here. You have to know the normal ranges of red blood cells, of the hemoglobin and hematocrit, the platelet count, and the white blood cell count. These are must-knows in this class at this level. There are a lot of test questions that you will not be able to answer if you don't know those normal lab values. So this might be a good place for you to get some flashcards just until you have those numbers down and those ranges down. After that, you're going to really have to know what these things mean. Okay, what does it mean if a red blood cell count is low? What does it mean if a hemoglobin is low? So the red blood cell is the cell itself. Most of the time, what we're mostly looking at is the hemoglobin and the hematocrit. The hemoglobin is on top of that red blood cell, and it is what is carrying the oxygen around to the organs in the body. So we're really concerned with this being in a normal range. If it's lower than 12, then they're probably not getting the oxygen that they need, which means the body's going to have to work a little bit harder to circulate that blood. When it gets below 8, that's when it starts to become a little bit dangerous for that patient. The hematocrit is the ratio of the volume of red blood cells to the total volume of blood. So it's really how viscous that blood is. The platelet count is important because platelets are what your body needs to clot that blood. So if you have a bleed somewhere and you have a very low platelet count, your body has no ability to clot. The white blood cells are for immunity, right? They're the ones that attack pathogens. So we talk about that a lot in this class too when we go through cancer, autoimmune disorders, we'll go through HIV/AIDS, so white blood cell count becomes really important. You don't have to know the ranges for MCV and MCH, but you should know what they are for. So the MCV stands for mean corpuscular volume, and that's the average size of the red blood cell. So when it's elevated, it means that we have these macrocytic or very large red blood cells. If it's low, then it's microcytic or small. MCH stands for mean corpuscular hemoglobin, and that's the average amount of hemoglobin that's present in on your red blood cell. So if it's high, it's hyperchromic, and if it's low, it's hypochromic. And hypochromic red blood cells, you can actually tell when you look at the red blood cell, they're very pale in the center. They're not able to carry much hemoglobin around. So we'll go over blood loss anemia first. This is pretty easy to understand. It's the loss of whole blood. So you're losing all the blood and all the components in the blood. It can be through an injury where the volume suddenly decreases very rapidly. If that happens, your compensatory mechanisms are going to start to kick in. So you're going to start breathing faster. Your heart rate's going to go up because your body is trying to still meet the demands of all those organs that need oxygen. So those mechanisms will kick in. Of course, those mechanisms will fail if you continue to lose blood. The chronic bleeding is a slow bleeding that can occur, and the body's going to try to compensate for it over time. This will lead to an iron deficiency anemia because you're eventually going to be using up all your iron stores to try to pump out as many red blood cells as you can to fill that void that chronic bleed is taken away from you. It takes about 3 to 4 weeks to replenish your red blood cell supply. So some things you'll see on your patient: their heart rate's going to be high, they're going to be breathing fast, they may be pale, cool and clammy, may have low blood pressure, and decreased level of consciousness is a late sign. That's when things are starting to get really serious. You may see some oliguria because the kidneys are going to try to shunt more fluid back into the circulatory system to keep that volume up. Unfortunately, that's going to just dilute your blood even more and make it seem even more, make you seem even more anemic. On the CBC, you're going to see a low hemoglobin, low hematocrit, low red blood cell count. If it's a chronic loss and your body's had time to try to compensate, you may see microcytic and hypochromic red blood cells, and that's because you're going to pump it out so quickly. You're also going to see low iron if it's a chronic blood loss. The treatment for that might be to find the source of the bleed, obviously, and stop it and treat that. That would be the primary thing to do. We're very conservative with blood transfusions. There's a lot of risk involved when you transfuse blood. You're going to go over that this semester. You're going to have some ATI work to do in that, and we're going to go over that in the lab too. But typically we don't transfuse at least until the hemoglobin is less than 8, and probably they're going to need to be symptomatic before we make that type of decision. Really goes case by case scenario. So our nutritional anemias are iron, B12, and folic acid. Just be aware that vitamin B12 deficiency is also called pernicious anemia. Remember, iron deficiency anemia is the most common one that we will see. So the reasons for the iron deficiency are those chronic bleeds, but also possibly malabsorption or decreased intake. Those are pretty unlikely scenarios. You might see that in older people or people who aren't consuming enough food, like alcoholics, for example. And then also during pregnancy, the need for iron increases, and when you're lactating as well. So you may not have any symptoms with this at all, but if you do see symptoms early on, there will be some fatigue, headaches, they may be pale, lethargic, cold intolerant. Late signs, if this continues without treatment, would be brittle nails, a sore, inflamed tongue, which is called glossitis, and cracks at the corner of the mouth, which is called chylosis. It's diagnosed through the CBC, so we're going to see less red blood cells and malformed. They're going to be microcytic and hypochromic, and again, we're looking at that iron. It's probably going to be low. To treat this, we're going to try to promote a diet high in iron. There's a great chart in your book, in your Pearson book, that shows the different foods for each of the nutritional anemias. Definitely take a look at that. We may also give iron supplements. If they're oral, you just need to make sure that you're making your patient aware that they may have dark stools, almost black looking stools. So that's a normal effect of iron. Just let them know that, otherwise they might think that they're having a GI bleed. It can also cause GI upset, so we usually give it with food, and it can cause constipation. If it's given IV, it's usually done in an infusion center. because the risk of anaphylaxis is pretty high. And if it's given IM, it's usually given via the Z-Track method. So vitamin B12 deficiency is less common, but some of the risk factors may be malabsorption, decreased intake, or a resection of the stomach or ileum, and we're going to talk about that this semester too. So things like gastric sleeves or gastric bypass, for example. Vitamin B12 is usually absorbed in the stomach and in the small intestine specifically. So some symptoms that you may see, you're going to see a pattern here. They're all kind of similar. They may be pale or even slightly jaundice. Glossitis again. They may have diarrhea. They may have paresthesias, so tingling in the fingers or in the lips. And then proprioception is spatial difficulty, so that can come off looking like the person's just very, very clumsy. They're just not aware of almost like they're not aware of their surroundings. The red blood cells may be numerous, but they're misshapen, and they may be large. So our treatment is to promote a diet high in vitamin B12. So again, take a look at that chart in your book. And we may give supplements. They can be oral or parenteral. So for folic acid deficiency, this is something that we see often in older adults or patients with alcoholism, or those who are on TPN. Sometimes if there's increased need for it, like in pregnancy or times of rapid growth, then we may run into a deficiency. And then anybody on chemotherapy, alcohol again, and celiac disease. Unfortunately, our alcoholics, they take in a lot of calories through the alcohol, but they're not getting very much nutrition, so they're often severely malabsorbed. But also alcohol suppresses folate, so this is kind of a double whammy with this. So they're probably definitely going to need that. Some type of supplement for this. So this person again is going to be pale, tired, short of breath. There's your glossitis and your chylosis again, and they may have some heart palpitations. Our red blood cells will be fragile and immature and small. So we want them to consume a diet high in folic acid, and they're probably going to be taking folic acid supplements. Here's a nice little chart that shows all of the different types of nutritional anemias, how you can promote some of these vitamins and minerals in your patient's diet. Please also take a look at the one that's in your book. It's very similar to this one, but you just need to know, especially for iron, there's heme iron and non-heme iron, so they probably need a combination of both. So make sure that you watch the next part of this lecture too.